So we have Dr. Arun who will be talking about something which he has devised. He'll be talking about the role of lasers in angle closure glaucoma, a very unusual topic. Over to you, Dr. Arun.
Thank you, AIOS. Thank you, Dr. Kirti, for organizing this course. I'm just going to give an overview of some of the alternative lasers in angle closure. The ability to use laser as a non-incisional therapeutic modality is immensely magical. We've been using these for decades and generations, but I think this is a good point to step back and acknowledge these two individuals, Dr. Rosa and Dr. Francis Las Prince, who gave us these lasers. More importantly, I want you to focus on the statement of innovation by Rosa, who said that an innovation doesn't come from sudden illumination. It requires a time of observation, a certain inclination to gamble, and the feeling that the present is already the past. So this is really a message to take home, to start thinking about what you're doing so that we can improve what we do at every point in time. So just to give you an overview of what lasers can achieve at the, in terms of countering pathology at various physiological levels, is, as far as angle closure goes, is it helps us relieve pupillary block by doing the iridotomy, allows outflow enhancement in the form of once we do the iridoplasty and trabeculoplasty, and inflow reduction when we do cyclophotocoagulation. Just the overview of iridoplasty is that typically it is indicated when there is persistent appositional angle closure following an iridotomy, and there is raised IOP, or this progressive synovial closure, or a situation wherein we label as plateau iris syndrome. Further applications are in situations such as acute primary angle closure glaucoma and lens-related angle closure glaucoma. These are the settings which most of you are aware of. The aim of the therapy is to achieve contracture of the iris like you see in this video without extensive charring, and hopefully the angle recess opens up following the procedure. So in general, I told you about the overview where iridoplasty can be applied. Some data on how effective it is as far as acute primary angle closure goes. Good data from Dennis Lam and group, who performed iridoplasty in 73 consecutive angle closure eyes. Basically, they were randomized to either iridoplasty or medication only, and the authors found that iridoplasty was able to achieve an intraocular pressure drop that was nearly a lot more rapid than medication could, and intraocular pressure was lower at various time points until up to 2 hours earlier compared to medication when iridoplasty was done. So they did conclude that it's a safe and effective alternative to medical treatment for acute primary angle closure. Some of the pros are the ability to thwart IOP at an early stage, earlier symptomatic relief, lower risk of medication-related side effects, and lower risk of permanent synovial closure. The complications are the cons are, however, damage to the endothelium, Urich-Zavare syndrome, and we have to understand that iridoplasty alone does not eliminate pupillary block. In terms of other scenarios, such as primary angle closure glaucoma, the effectiveness is about 60%, and similar in plateau iris syndrome, and also effective enough in phacomorphic glaucoma. Our own trial from Singapore, wherein we randomized about 40 eyes in each group, we noted that the survival rates at 1 year was close to 60% following iridoplasty compared to about 87% when we treated them medically. See, the overall effectiveness of angle closure is lower, of iridoplasty in angle closure is lower when compared to prostaglandin therapy. It is a useful surgical therapeutic modality in certain indications such as plateau iris syndrome, and selective application in acute primary angle closure, phacomorphic, and so on. But with the immensely improved cataract surgical skills, iridoplasty may have very selective applications in our armamentarium at this point in time. So moving on to selective laser trabeculoplasty, the selective laser trabeculoplasty B has been hovering around for many decades, but the uptake as a standard option in a therapeutic armamentarium remains low, but things are changing. We all know that the role of medical management and its effectiveness is irrefutable, but it's intertwined with challenges such as poor adherence, systemic side effects, poor quality of life, and negative impact on the success of subsequent surgical intervention. These challenges are similar to open angle and angle closure disease. The 6-year outcomes of the LIGHT trial is rather positive in terms of its outcomes, wherein they noted that there's lower disease progression in SLT. 70% of the subjects were drop-free after SLT, and there are more incisional surgeries that were required in the medication form. This could be similarly applied to in our management of angle closure disease. Our own data about SLT in angle closure, when we recruited about 50 eyes in each arm and randomized them to SLT versus medication. All of these eyes had an iridotomy in at least 180 degrees of open angle, and the IOPA response was noted similar at 6 months between the SLT and the medication arm. The overall success rate was close to about 60% in the SLT arm and about 80% in the medication arm. So in general, it is an effective therapy. The mean IOP reduction with SLT was equivocal to prostaglandin therapy at about 6 months. Now we move on to the innovative aspect of this laser that is probably that will probably be accessible to many of us. This restless innovator, Professor Michael Belkin, most of you would know, identified the main pain point, that is gonioscopy, and he thought about a way to eliminate this as part of the SLT procedure and came up with the platform of direct SLT, wherein you can deliver the SLT to the angle without any gonioscopy. It's basically a quick Q-switch laser. It has an image processing algorithm that locates the target area on the limbus, and it's able to deliver about 120 laser pulses in under 4 seconds to all around the limbus. So we'll see a video of this that will probably be more informative on how the technology works. There audio to the video?
400-micron beam on the limbus, and as the laser energy penetrates the ocular tissue, it scatters, forming a cloud of energy reaching the trabecular meshwork. To better understand, let's look closer. The typical energy delivered per pulse is higher in DSLT than SLT. In DSLT, the energy is directed through the limbus, and in SLT via the cornea. DSLT allows energy to scatter throughout the tissue, resulting in lower energy transmission to the trabecular meshwork. Energy per pulse reaching the trabecular meshwork is similar in both therapies. Multiplying this energy by the number of spots per treatment would result in a similar total energy reaching the trabecular meshwork in both therapies. The resulting effect is a lowering of intraocular pressure. DSLT offers a sophisticated non-contact therapy, effective as a first-line treatment for glaucoma and OHT.
So this is from our trials where we've been able to deliver the SLT in a very quick and efficient way. You notice that the delivery can be done either with the patient standing or seated, and from there, you know, the therapy is completed. It's delivered about 120 shots of laser without the aid of gonioscopy. So the current evidence is very limited. The Glorious study is an RCT that compared DSLT with SLT. They noted that the overall reduction was very similar in both the arms, and it is currently FDA approved, and you probably hear about its launch very soon. In our own trial of DSLT in angle closure disease, especially in eyes that have been iridotomized in at least 180 degrees of open angle, the effectiveness, which is indicated by the green line at 4 months, was pretty effective. We noted that the intraocular pressure drop ranged from about 25 to 36% at about 4 to 6 months, and 76% of the subjects have remained medication-free. About 38% needed retreatment, and overall, the SLT has demonstrated immense potential to keep a patient drug-free. The ease of effective laser delivery through the DSLT has opened up an exciting era for glaucoma management. The costs and logistics of the management of using SLT as a routine therapeutic option may not be feasible for every healthcare system, but appropriate case selection and application of laser widens our armamentarium to manage angle closure effectively. Thank you all.
Thank you, Dr. Arun, for that eye-opener.